All right, well, it's the top of the hour. I'm going to go ahead and get started. So first of all, welcome to everyone to the Aerospace Medicine Grand Rounds. We appreciate your attendance. And let me run through a few things first before I introduce our speaker. First of all, I'd like to remind everyone to mute their microphones and block your video. It's very distracting to have background noise and video, of course. So we appreciate it if you block both of those. I prefer that you save your questions for the end of the session so that we don't disrupt the rhythm of our guest's presentation. And also, the next thing is I'd like to thank Rachel Fowler for setting up our session today and getting everything organized. She does a superb job of keeping us all on track. I'm going to turn it over to her in just a minute here to speak about CME and maintenance of certification credit that you can get for this session. So with that, I'm going to go ahead and let Rachel step in and speak, and then I'll introduce our speaker.
Thank you, Dr. Powers. I just want to remind everyone that the disclosure slide that was displayed before the presentation will also be displayed after the presentation. If you don't have the number or the code, I can also post that in the chat. And if you have any questions, let me know.
Great, thank you, Rachel. Well, this morning we're very honored to have Dr. Mark Melin speak with us. The various issues of spaceflight, of course, are very important to NASA and the aerospace medicine community. And Dr. Melin has had some very unique research and insight into the potential problems with SANS and other things related to the lift system. So with that, I'm going to go ahead and introduce him. We appreciate his presence here. Dr. M. Mark Melin is a surgeon and medical director of the Health Wound Healing Institute and adjunct associate professor at the University of Minnesota Surgical Department. His interests in educational niches include the management of lymphedema in wounded patients, the endothelial glycocalyx, adjunctive micronutrient application of wound care, micronized purified flavonoid fractions, wound pH and biofilm management, and emerging technologies in wound products and wound technologies. He participates in the educational activities of the surgical department residency training program. So he resides in Minnesota, and I believe he's 4 grown children and 3 rescue dogs. So many facets to Dr. Melin. With that, Dr. Melin, again, thanks for joining us today, and I'll turn it over to you.
Thank you, Dr. Powers. I appreciate it. Let me hop into screen share here. And we'll get the slide presentation. Now, we've got about 50 slides we're going to get through, and then we'll leave about 10 to 12 minutes at the end for questions. So the title is Lymphedema of Venous Etiology, what I have termed as an acronym of LOVE, and Spaceflight Neuroocular Syndrome, SANS, Environments, the Endothelial Glycocalyx, and Common Nutrients. One of the big themes that's going to come through is that we as physicians really under-recognize lymphedema. The current standard phrase for dealing with what I deal with as a surgeon or a wound clinic is phlebal lymphedema. So that's venous etiology with associated lymphedema. But in reality, lymphedema is the driver of almost everything I see in our wound clinic. And I'm going to demonstrate how this all plays out in terms of what we do in the wound clinic, and then how this led to my interest in these into the SANS component. I have no disclosures that are applicable to this. Now, one of the first physicians, and obviously the first physician into space, was Dr. Joseph Kerwin. And as reading back in his history and exploration, what he's contributed, this quote really stood out to me as applicable to what we're trying to do right now. In that exploration medicine is understanding and dealing with normal humans in abnormal environments. And I would add on a component to that, saying that we now have humans that are living in such abnormal physiologic environments within the United States that it's resulting in significant pathological long-term inflammaging components. So we're seeing epidemics in diabetes, obesity, metabolic syndrome, hypertension, which then results in downstream effects of coronary artery disease, cerebral vascular accidents, blood clots, pulmonary embolus. So we've taken humans and we've really altered our food environment. We've altered our physical environment. We're exposed to things I think that genetically we were just never set up to deal with. And hence what we're dealing with in low Earth orbit is directly applicable to what is occurring on in the United States. And the more we figure out what's going on in low Earth orbit, it can really have a profound understanding for us, because people pay attention to what NASA's doing. And there's a disproportionate interest from my colleagues. So when I'm trying to get my colleagues to listen about what we're trying to do with lymphedema, it's difficult. I think if we can have an impact on what's occurring lymphedema-wise in low Earth orbit, we can make a significant impact on demographic health. So these are the two emerging chapters in medicine within the microcirculation. We're going to hit hard on the microcirculation because as a board-certified vascular surgeon, I spent my career dealing with macro vessels, so vessels I could actually sew together. I stopped doing vascular surgery about 4 to 6 years ago to concentrate on sheer wound and venous and lymphatic components. But ultimately, I've turned from dealing with big blood vessels into the blood vessels that are the size of my hair or smaller. So in that 15 to 5 micron range. So your hair is 15 microns, where all delivery of oxygen and nutrients occurs is in those 5 micron vessels, which is the same size as red blood cells. So the red blood cell is the transporter of oxygen and nutrients. So the microvascular endothelial glycocalyx, which we're going to go into some detail, is this boundary that is a very functional, dynamic interface between the red blood cells and the endothelial cells. Without the glycocalyx, the endothelial cells are non-functional. So this is going to be a critical component of this discussion. Now, the other aspect is lymphatics, and the lymphatics also have an endothelial glycocalyx, and lymphatics are largely ignored in medicine because people don't understand them. They're not taught in medical school. We're still talking about the old Starling curve of 1896 that Dr. Ernst Starling developed in his lab in the United Kingdom. And we just haven't caught up from the testing aspect. Therefore, it's still not being taught in medical schools. I have I have 3 kids that are in or starting medical school this fall. It is still not being taught despite the significant revision that occurred 5 years ago. Now, the other important thing to put into perspective is there are 200 trillion, that's trillion with a T, chemical reactions per second in the human body. So ultimately, things like artificial intelligence and using computing to pull all this together is going to be critical as we're trying to ascertain what is going on at the endothelial cell level where all oxygen and nutrient delivery occurs. So again, 50 to 60,000 miles in a typical adult human down to the level of the 5 microns. And it's estimated that the surface area is like that of a tennis court. So think of this as a solar panel. And diabetes is basically a big cloud over the solar panel. It cannot take the energy of the nutrients that are consumed and translate it into functional outcome. So losing this square surface is like a cloud over your solar panel. So with the significant surface area, every bit of it is layered by the endothelial cells. And this is the interface, again, of the blood, the shear forces. And the shear forces then go through something called mechanical transduction that we're going to talk about that leads to production of cytokines and other factors that result in local, regional, or systemic impact for either health or dishealth. This boundary is also important for regulation of rheology, so perfusion, whether a red blood cell goes down one route or another route depends on what's going on within that local area. So hemostasis, coagulation, inflammatory responses, and of course angiogenesis that can be either pathologic, such as in diabetic retinal disease where you get pathological angiogenesis, versus in legs that I deal with where there's occlusion of blood vessels and you get necessary angiogenesis to increase perfusion. So one of the significant things is when we have edema in the local region, it decreases perfusion. We're going to talk about this multiple times during this time. So these are all functions of the glycocalyx, endothelial cell interaction. Now you might be saying, why haven't I heard of the glycocalyx if this has been around and it's so important? Like lymphedema, it's one of these areas where physicians in busy practices just aren't paying significant attention. They don't have time to read. The one group of physicians that's paying significant attention is the anesthesiologists, because their practices within the operating room on the patients that we're operating on have an impact on long-term outcomes. So if they get fluid overloaded, it tends to shed the glycocalyx. That results in long-term outcomes that are poor, such as increased cerebrovascular accidents, increased myocardial infarctions. And we all know that if you fluid overload somebody, you have a higher chance of negative impact. So at the base of the endothelial cell function is endothelial nitric oxide synthetase. So this is a critical component of overall nitric oxide production. Now there's several forms of nitric oxide. There's endothelial, there's inducible or inflammatory, and then there's neuronal nitric oxide. We're going to focus on endothelial nitric oxide. So chronic inflammation has been well associated with an increased risk for cardiovascular disease, both from a morbidity standpoint as well as a mortality standpoint when you compare it to general population. So we all know that people that have diabetes, that are on dialysis, have hypertension, hyperlipidemia, utilize tobacco, have severe obesity, they all tend to have worse long-term outcomes. They consume a disproportionate component of the healthcare economics, and it's because they have this chronic background of inflammation. Well, most of this is at the endothelial cell level. It's uncoupling of endothelial nitric oxide synthetase, which results in decreased nitric oxide, and this has a huge impact subsequently on microvascular dilatation, microvascular perfusion, permeability, and ultimately in how the lymphatics work. And lymphatics are directly associated with the immune system. So if you look at people with lymphedema, we all know they have an increased risk of developing things like cellulitis. This gets right back to endothelial nitric oxide synthase uncoupling, because you have decreased nitric oxide, which decreases lymphangion functionality and decreases immune functionality. So where I deal with it the most right now is in our wound clinic is with venous leg ulcers, which has a significant lymphatic dysfunction or lymphedema component. Depletion of endothelial nitric oxide synthetase cofactors like tetrahydrobiopterin, which is BH4, and this alone, there's now papers that have been written on this cofactor as a significant independent actor within this cycle. L-arginine, of course, and then citrulline is a part of this cycle. All of these things end up being facilitators in increasing nitric oxide production, and likewise, if you have decreases in them, you lose the ability to produce nitric oxide, resulting in premature development of cerebrovascular or cardiovascular diseases. Now, I think there's subclinical cardiovascular disease where you can have changes that we all know that if you stop smoking, change your eating patterns, exercise, treat your hypertension, we know that those cardiovascular long-term outcomes can be mitigated, and you can have a good long-term outcome. So most of this, diabetes, dialysis, hypertension, it's all acceleration of normal aging. So again, that inflammaging component. And so recoupling of endothelial nitric oxide synthetase and maintaining endothelial nitric oxide production has become a mainstay of what I focus on every single day in our clinic with every single patient, because I can't get wounds to heal unless we maximize microvascular perfusion, unless we maximize immune system functionality, and specifically if we don't maximize lymphatic function. And where this has all come down to is that we're focusing on a significant part, not just of wound care and local wound care environment with pH, etc., but it's also nutritional. And I rarely speak to our patients about protein because we're a country of over-proteinized people. We eat plenty of protein. Where I'm focusing on is the adjunctive micronutrients that maximize recoupling of endothelial nitric oxide synthetase. Our wound clinic is unique in this, in that even those around us, as we're educating wound clinics around us, because we want all patients in the Twin Cities to do well. We'd love to have all patients nationally do well, but it's going to take adjunctive micronutrients to maximize endothelial nitric oxide synthetase. This is where B12, folate, B6 come into significant play, because these micronutrients fuel and reconnect and help us, as we're going to demonstrate. So if we look at, this is going to be the introduction. We're going to hit this slide a couple more times. So 5-MTHF is folate, and we can get it either natural through green leafy vegetables, or we can get it synthetically. Now, in the United States, almost all foods are fortified with folate because we know that lack of folate has significant demographic implications, especially for, say, pregnant moms. So we can run into higher risk of neurological complications. So if you look at the top part of this coupled endothelial nitric oxide synthetase and look at the scale, this is down at the 5 micron level. This is one red blood cell going through. In that 50 to 60,000 miles of our length, this is 80 to 90% of our entire vasculature. So everything that occurs is occurring at the microvascular level. And so you can see where the BH4 component, which interchanges with BH2 during the methylation process to create L-arginine, that results in being transformed into L-citrulline and nitric oxide, which then has all the downhill effects. Vascular relaxation is one of those effects. In the lymphatic system, it also has a significant impact on immune system functionality as well as lymphatic contractility. Now, if you go on the underside, the uncoupled endothelial nitric oxide synthetase results in a whole host of negative implications. So we lose our ability to transform L-arginine into nitric oxide and citrulline. We have direct production of reactive oxygen species in several forms, which create oxidative stress. At the end of the day, oxidative stress systemically is what leads to increased morbidity and mortality of cardiovascular systems. Now, the important thing to focus on here is fluid leakage, because if we look at the interface between the endothelial cells, which are right next to the red blood cells, and fluid leakage, we're missing one small component here, and this is where the glycocalyx, the endothelial glycocalyx, is going to fit in. And by the end of this talk, you're going to understand why fluid leakage is directly related to endothelial glycocalyx functionality. So to think about the glycocalyx, I'm going to create a framework. So just like a computer has hardware, software, and a power source, the endothelial glycocalyx has hardware in the form of glycoproteins, proteoglycans, glycosaminoglycans, caveolans, and then the micronutrients are a significant component of glycocalyx functionality. So you need zinc, you need folate, you need D3. So vitamin D3 has actually been shown to work directly on endothelial cell functionality. The B12 and the B6, which we touched on. So that's the hardware. Then there's the software. The software comes in the form of genetics and epigenetics, which results in appropriate or inappropriate methylation that we know as single nucleotide polymorphisms. So these so-called SNPs have a huge impact on how our body reacts to oxidative stresses. So in the situation where we've had a change that we're dealing with now with MTHFR changes, we see a difficult time in terms of resolving and healing lower extremity ulcerations unless we provide extra pharmacologic sources of nutrients. So think of it as gears in a clock. The normal gears of a clock keep time for the body. However, when you have SNP, when you have single nucleotide polymorphism changes, it's like taking away teeth of the gears of the clock. It doesn't work together. To get it to work together, you have to give these other adjunctive micronutrients to re-engage the gears of the clock to produce then the substances that can deal with the oxidative stresses. And then you also need a power source. Now, the power source for the glycocalyx is actually shear. So it's literally just fluid flowing across the glycocalyx that gets it to wave like wheat in a Kansas field with wind. So the micro and macro shear results in mechanical transduction. So the ultimate power source goes through the glycocalyx into the endothelial cell to impact the cytoskeleton, which then ultimately gets transmitted to multiple intracellular components, including the nucleus, which has an impact on outcomes. So here's a picture of the glycocalyx. And again, look at the scale. This is a 1 micron scale. So the glycocalyx thickness is incredibly thin. However, it's actually incredibly thick when you scale it down to the size of the endothelial cell. So the reason people haven't noticed this was preparation. So if you treat this with formaldehyde or other ways, you'll totally wipe this away. One of the first ways to look at this was Luft did this in 1966 and could barely see some of it. But lanthanum staining, fast freeze staining, there's a number of other techniques that help to preserve it so that you can then examine it. So it looks like really fine hairs on top of the endothelial cell, and this is what waves when you have shear to produce impact. Now, the way to think about, and the acronym I'm going to give you to remember what the glycocalyx does is EPIC. So, oh, I apologize. Let's see. I just got to get back to my screen here. give control. Rachel?
Dr. Melin, we're still seeing your slides.
Okay, I hit some wrong button and I just got to get back to my slides here. There we go. So EPIC is the acronym. So E stands for endothelial function. This is where shear-induced nitric oxide synthesis occurs, and also the SOD, so the superoxide dismutation. So taking care of SOD is important in terms of that oxidative stress component. P is for the permeability. So think of glycocalyx like a Gore-Tex barrier. So it's a permeability barrier that prevents inappropriate leaking and interstitial fluid accumulation. When you lose your glycocalyx, like in times of trauma, sepsis, diabetes results in shedding or thinning of the glycocalyx, you'll have more interstitial edema. Lymphedema is a great example. When you have lymphedema in the lower extremities, you've lost your glycocalyx, you have significant accumulation of interstitial fluid. So, and then the I stands for inflammation. So this prevents adhesion of white blood cells. So the white blood cells don't produce the free oxygen radicals. Now, there's ontologically and teleologically appropriate times. If I stick a needle into my finger, I expect to lose the glycocalyx in that area. The white blood cells then are going to transmigrate to fight whatever bacteria was on the tip of that needle. When you take the needle out, over the course of about 7 days, that redness and that inflammation will go away. The glycocalyx reestablishes itself. You've got reestablishment of oxidative balance and oxygen nutrient delivery. So there's times where it's appropriate to shed the glycocalyx, and there's times where it's inappropriate to shed the glycocalyx. And the C then stands for coagulation. When you lose the glycocalyx, you're going to expose things like antithrombin 3, factor 5, and all the other factors that set up the cascade to result in platelet adherence that then sets up the triggering mechanisms to result in microthrombi development. And once you start to get microthrombi development in these vessels, it'll cascade into macrothrombi that we know as a deep venous thrombosis or superficial thrombophlebitis that then can translate into things like pulmonary emboli. Now, this also occurs on the arterial side where we can have microthrombi occur, and that turns into something like a stroke or turns into something like a myocardial infarction or an embolic phenomenon. So EPIC is just 4 parts of the glycocalyx to remember in terms of endothelial function, permeability like Gore-Tex, inflammation prevention, and coagulation prevention. The R component would be rheology. So it helps direct where you should have red blood flows flowing during periods of either rest or exercise. So as we're all sitting here today, vast amounts of our muscle mass doesn't need significant oxygenation because we're not exercising. So that part of the microvasculature is actually relatively closed. There's minimal, if any, red blood cells flowing through there, and the glycocalyx makes it so those vessels don't thrombose in that moment. Now, when we go to exercise, those vascular beds will open or vasodilate. You get more delivery of oxygen and nutrients into those muscles as you're exercising, and then you get more delivery. So there can be, depending on your state, your environment, what you're doing, you'll have different states of perfusion during different times. This paper came out in 2021, really does a phenomenal job of connecting the endothelial glycocalyx to coupling and uncoupling of endothelial nitric oxide synthetase. So if we walk through this, again, see the shear stress. So that's, again, this is in a 5 micron vessel. So the components of the endothelial glycocalyx include, again, that hardware components of syndecan and heparan sulfate. So not heparan sulfate like we get from the intestines that we use for IV injection, but heparan sulfate, but does exactly the same thing. And you can see these are connected to what's called CAV1. These are the transmembrane that connects then to the component of endothelial nitric oxide synthetase that as you wave, as you have the shear stress, it activates so that you get coupling of endothelial nitric oxide synthetase, which maximizes nitric oxide production, but it also then decreases reactive oxygen species. So think of it as a teeter-totter, because you want to have the antioxidant system really high on the high end of the teeter-totter to decrease reactive oxygen species, and then that targets within the nucleus to make sure that you're having a subsequent decreased cardiovascular morbidity. Now, in pathological states where you've had shedding the glycocalyx, so think again of smoking, hyperlipidemia, decreased shear, sepsis. So you get these things that are called shed daces that come through, and they literally, like a Pac-Man, eat through components of the endothelial glycocalyx. This results in uncoupling of endothelial nitric oxide synthetase, which creates a whole downhill vicious cycle, because now you have decreased nitric oxide, but also uncoupled endothelial nitric oxide synthetase actually increases reactive oxygen species independently. So now the teeter-totters in favor of reactive oxygen species that then just has the oxidative stress within the microvasculature. And again, this ultimately decreases end organ perfusion and creates interstitial edema. So lack of endothelial glycocalyx results in endothelial hyperpermeability and interstitial edema collection. So the force of the shear is also important. So if you look at what's called the glypicin attached to lipid rafts, and think of lipid rafts as sitting in a ocean. So when the wind blows, they'll all float down to one end, and that's called clustering. So you can see that's at about 15 dynes per centimeter squared, so relatively high. So think of that as exercising. So as you cluster these lipid rafts, you're going to have increased eNOS activity, increased nitric oxide production, which makes sense. When you're exercising, you need more nitric oxide. Now, when you're at low level rest, you don't need as much eNOS activity. Therefore, you don't have the clustering, and that's like our muscles at rest right now. So they've clearly connected the dyne force with eNOS activity. At rest, you have less. At higher activities, you have more. It makes teleological sense. So again, when you shed the glycocalyx, now you've lost nitric oxide availability. You have increased oxidative stress. You have leakage of macromolecules, which again impacts interstitial edema, increased platelet adherence, increased thrombin generation, and increased leukocyte adhesion. All these things can be teleologically appropriate in things like when you're fighting a major infection. And we've seen this actually with COVID. All these things, COVID causes shedding of the glycocalyx. It's been shown beyond a shadow of a doubt in multiple papers now. And the thinnest place for the glycocalyx is actually within the lung. So again, makes sense because it's an endotheliolitis as a virus. Now, restoration of the glycocalyx, there's several things now that have been shown to help restore a degraded glycocalyx. One of the most significant that we see used in the intensive care units is albumin. Albumin is a significant component of the plasma proteins, makes up probably 50% of the endothelial glycocalyx. And one of the components that goes with albumin is sphingosine 1 phosphate. So think of it as miracle grow. Albumin plus sphingosine 1 phosphate together helps restore all of the epic factors that we talked about within the glycocalyx. So if you want, and then there's other things like liposomes and other things that people are now working on as additional factors to help restore the glycocalyx. Recovery time was demonstrated in 2009 through using enzymatic components like hyaluronidase and heparinase to decrease or eliminate the totality of the glycocalyx. So you can see at day 0, after the enzymatic degradation, the thickness is down to 0. Now, TNF-alpha, which we see in areas of sepsis, is another way to shed the glycocalyx. Restoration under good environmental control and elimination of the factors that are causing shed the glycocalyx typically is at about day 7. Again, if you translate that to your clinical experiences in the intensive care unit, once you get control of sepsis, we typically see over the course of the 7 days a significant diuresis. We see an increase of systemic vascular resistance because we don't have that massive hyperpermeability area. So in sepsis, you've completely lost your glycocalyx. You can't maintain an SVR because peripheral resistance is so low because everything is so hyperpermeable. You get all the interstitial fluid. Again, with restoration at day 7 after removal of the offending agents, now you have a significant diuresis, increase in the SVR, and recovery of organ function. Lymphatics, we know that the baseline component of a functioning lymphatic is the lymphangion, which is composed of valves as well as actin filaments. And Laura Santambragio up at Weill Cornell is one of the first now that's talking about the glycocalyx component of the lymphatics. Again, very important in terms of lymphangion contractility because contractility is based on nitric oxide production as well as overall immune functionality. And again, back to that episode of we know that people that have lymphedema of the lower extremities tend to have higher rates of lymphangitis. Now, this paper that came out in the Annals of Vascular Surgery in 2018 was one of the first to connect venous hypertension resulting in shedding the glycocalyx and then restoration with a medication that's available only over in Europe, which is called sulodexide. Now, sulodexide is a fast-acting form, this is oral, of heparin sulfate and dermatan sulfate. So they've shown that using sulodexide as a highly purified glycosaminoglycan can help restore the glycocalyx over time, again, getting rid of the offending agents. And now there's a plethora of studies that have shown that MTHR has an impact, both of the association of varicose veins, the association of superficial thrombophlebitis, association with interstitial edema, and then restoration of those has been shown to be with, again, common nutrients. So vitamin B12, correcting folate deficiencies, correcting vitamin D deficiencies, correcting B6. So again, very common nutrients. They tend to be vastly overlooked by physicians. And I think it's because we're not making the link between these components and what's going on at the microvascular level. So in our clinic, in the last year, we have really begun to focus on MTHFR polymorphisms because this results in that ineffective one-carbon metabolism and genetic influences, which we now recognize as we're discussing, has a direct impact on the glycocalyx. Printed literature in this 2015 Seminars of Vascular Surgery was really one of the first times that I saw a significant discussion about MTHFR polymorphisms impacting the ability to heal lower extremity venous ulcerations. So about 20 to 40% of our legs are hard to heal, and it's simply recoupling endothelial nitric oxide synthetase, which we're doing with treatment with B12, folate, and B6. And then we're also routinely adding in what are called micronized purified flavonoid fractions. So these come from the citrus, the rinds of oranges. It's like taking one pill that has 20 orange rinds. And the specific flavonoid, there's over 5,000 flavonoids. This specific one is hesperidin diosmin. So we use this regularly now, not only in our venous leg ulcers and our lymphedema patients, but I'm also using this in all our diabetic patients because all our diabetic patients are now recognized, peer-reviewed printed literature, to also have lymphedema. So the lymphatic dysfunction, the interstitial edema collection within our diabetic patients is just like our venous leg patients. And so treating this appropriately minimizes that amount of interstitial edema, which re-maximizes microvascular perfusion within our diabetic patients. We had in high-dose vitamin D3 at 10,000 units per day, high-dose vitamin C at 2,000 units per day, because the 2,000 units is a good way to deal with the antioxidant components. And now we know that vitamin C at that dose also has a direct impact on endothelial cell function. If patients have been on steroids, we add in 10 days worth of vitamin A. We stop the simple sugars, which are certainly inflammaging components. And we watch the phosphorus level, especially in diet sodas and regular sodas, because this impacts calcium functionality. And calcium is one of those things that, again, that helps with recoupling of endothelial nitric oxide, as well as with muscle contractile. Of course, get people off of tobacco. We've focused on Mediterranean style diets because, again, this maximizes flavonoids, extra virgin olive oil, and the other components that will help in terms of overall microvascular perfunction. One of the big medications that increases lower extremity edema is norvascular amlodipine. So every time we find a patient on this, we stop it because, again, it disproportionately impacts edema. And then, again, diuretics don't work for lymphedema. And this is an ongoing propagated thought. It really actually makes things worse in the long time because you're taking the fluid out of that proteinaceous deposition with the interstitial fluid, which turns it into like a really, really runny oatmeal to a thick oatmeal. Once it's a thick oatmeal, you can't get that out through the lymphatic system. So on our campus, 88 patients we determined MTHFR status September 2019 through March of 2021, we actually found a 52% abnormality rate. And that makes sense because we're dealing with the hardest to treat wounds. So we have a concentration of patients. And I think if you actually look at this in the general population, we're still not above the normal. It's just that we're a concentrated spot because of the difficulty of healing these wounds. So we had 18 women, a combination of heterozygous and homozygous, and then 28 men that were abnormal, again, heterozygous, homozygous. Now, if you ask me from a clinical standpoint, can I tell the difference? I cannot. And we've had to stop drawing MTHFRs because we are getting such significant feedback from insurance companies about the cost. So what we've done now is we just treat everybody in our wound clinic exactly the same. And I'm writing out the same prescriptions 20 to 25 times a day for patients to maximize, just assuming that they all need recoupling of endothelial nitric oxide synthetase. So within the one gravity environment of our wound clinics, we're emphasizing treatment of lymphatic functionality, because when the lymphatics are engorged and you have interstitial tissue that is really full of fluid, it compromises by literally just mechanical compression of the microvasculature. And when you have that compression, you can't get perfusion. So the analogy is Amazon. If you want to shut down Amazon, you shut down the highways or the driveways. It's shutting down the driveways because all delivery occurs within driveways. That's where the driver's dropping off the packages. That's where the red blood cell is dropping off the oxygen and the nutrients. Within the big highway systems, that's simply transportation. So when I was doing macrovascular surgery, the body would develop collaterals around occlusions of things like the iliac arteries, around the femoral arteries, popliteal arteries, etc. But if you shut down the microvasculature, the 5, 10, 15, you're going to lose perfusion of oxygen and nutrients. You'll have cell ischemia and cell death. People are still under recognizing the importance of edema and just even making the diagnosis, because on the left-hand side, many people would look at that leg and say, I don't see edema, and they're not picking it up. This is one of the biggest things to prevention of wound healing. So again, think of it as a flooded farm field. No farmer is going to put seeds and manganese and nitrogen and phosphorus into a field like this. You have to get the field drained with drain tile. And we do the same thing within our wound clinic, because we don't start using any advanced products until we get the drain field, the lymphatics taken care of within these lower extremity ulcerations, both diabetic as well as venous. And oftentimes what's happening is, once we get the fields drained, once we get the lymphatic component functioning in these legs, they never need an advanced wound care product, because the regenerative restorative components of the legs is such that it wants to recover on its own. I'm going to show you a few examples. So whenever we see legs like this, and this is a guy I've been dealing with for a long time, he's got hereditary type lymphedema that's been incredibly difficult to deal with. You can see how red and inflamed he is. And when you see ulcers like this, that is end tissue ischemia. He's not getting oxygen nutrients, and it's because there's too much interstitial fluid here to deal with it. So here's a leg I dealt with last October, tendon exposed, morbidly obese, fixed contracture on his knee, sarcopenia, loss of popliteal. So he can't actually, when he has a difficult time walking. So I took him to the operating room. We debrided out all the necrotic tendon. And then I ended up keeping him in the hospital for about 10 days, hypochlorous acid to decrease the wound pH. We ended up doing one skin graft. Now, the difference from October to February, the thing I want you to notice is restoration of dermal thickness. I didn't skin graft the entire leg. All I did was skin graft where that tendon was exposed, but look at how the rest of the dermis has restored and regenerated to a normal thickness. This is the benefit of maximizing lymphatic functionality, of giving micronutrients, of maximizing lymphatic function and recoupling endothelial nitric oxide synthetase. So in the course of 6 months, he regenerated his own dermal thickness. I just had to skin graft one spot. This happens routinely in our patients, and here's multiple pictures where we've done exactly the same thing in these patients and no advanced tissue products. So if you look at our overall functionality, we're really saving on these advanced tissue products and decreasing overall the cost of care. But you can see also how the dermal health has significantly improved. Now, the thing I'd like to see longitudinally in the long term is, how do these patients do from a cardiac standpoint, renal standpoint, cerebral vascular standpoint? Because I think ultimately by giving micronutrients and treating the lymphatics, we're actually treating systemically the body, not just local, regionally in the legs. The other significant component, a whole nother lecture, is the impact of histamine in these legs, and the histamine fits in the hyperpermeability. So decreasing histamine in these legs really decreases hyperpermeability. It's the same thing with allergies in the spring. You get secretory rhinorrhea. What's the first thing you grab? An antihistamine. So histamine plays a significant component in the hyperpermeability. So what I see every day in the wound clinic now is at the microvascular component, and it's really a war at the cellular level between oxidative stress and balancing that teeter-totter of oxidative stress. And I can't handle this just by doing macro things like wearing compression, lymphatic treatment, etc. It takes the adjunctive micronutrients to systemically treat that 50 to 60,000 miles. It's impossible to treat it without these adjuncts. Now, the lymphatic system, one thing to understand about the lymphatic system that is a relatively new concept, although has been out there for a while based on Guyton's principle from the 1960s, is the lower extremities are set up to be either subatmospheric or near zero. So actually the lower extremities are like a straw. When you take the bellows of the lungs and inspire, expire, and the diaphragmatic muscle function, and then walking, that basically all draws up fluid out of the lower extremities. So one of the ways, so this is a really important principle, again known as Guyton's principle, but the lower extremities are preset to suck the fluid out of the lower extremities in a 1G environment. That's how you get fluid from the ankles all the way up to the subclavian levels, and the valves are an important part of that. So think of it as an escalator. It moves from valve to valve to valve, but it's important on that negative subatmospheric component to help draw that fluid up. You lose that in weightlessness. So when you continue to breathe, what I think is happening is that you continue to draw through Guyton's principle. You bring it all the way up to that shoulder region, but now because the head and neck is gravity dependent and doesn't have that muscle component nor Guyton's principle, it tends to congregate in the head and neck, hence that 2-liter fluid shift. So ultimately things like the lower body negative pressure system and all those things, it's preventing that from ultimately going up in that component. So classic paper 1996, this helped show again what was happening in terms of plasma volume decreasing, headward body shift. I thought one of the most important statements from this paper was increased permeability of capillary membranes may be the most important mechanism causing spaceflight-induced plasma volume reduction. I think this is an incredible statement because it speaks directly to the glycocalyx, which wasn't on anybody's radar at this point. So again, the glycocalyx exists in arteries, veins, and the lymphatics have to pull up all fluid. We know this because of the revised Starling curve. Now, this again is a whole lecture in of itself, but as physicians, we were taught in medical school that the Starling curve means that 80% of fluid is reabsorbed into veins post-venule. So it goes from arterioles to venule, and the fluid is simply picked up. We know because of the revised Starling curve based on the glycocalyx as an impermeable barrier that actually no fluid is reabsorbed into the veins. It has to go into the lymphatics. Hence, lymphatics are now mission critical. Now, this was actually really shown in 1996 at about the 100th anniversary of the Starling discovery by Dr. Levick, Dr. Mortimer out of UK, and then Dr. Roxon out of Stanford wrote this really seminal paper in 2014, which put this on a lot of people's radar screen. I'm going to admit, and I'm embarrassed, I missed this paper in 2014. I didn't really get into understanding this until about 2 years later. And once I started to look into the glycocalyx, it totally paradigm shifted every thought process I have. I look at every paper differently. I read the Journal of Vascular Surgery differently. I read venous studies, lymphatic studies, all through the eye of the glycocalyx, and every time I see permeability, I think the glycocalyx is gone. That's why you're having permeability. That's why you're having interstitial edema. So again, to show or to show Dr. Ebongs out of Northeastern, the glycocalyx is like your lawn. It's more like a mountain flowers. There's multiple components to it, but the lawn component, think of it waving. This is what keeps it healthy. Now, when you have shed ACEs, when you lose albumin, when you lose other components of your glycocalyx, you end up with microvascular permeability and all the things. Now, albumin, again, has been shown now multiple times, multiple peer-reviewed studies, as a significant component of the endothelial glycocalyx. If we lose albumin, have low albumin, which we know to exist in diabetics where they have microalbuminuria, it's because the glycocalyx has been damaged. So ultimately, with glycocalyx shedding, and here's a high magnification showing of this was without lanthanum staining, so the glycocalyx was shed. You can see it's a bare surface. most of us would say, well, that's normal endothelium. Actually, normal is below where the glycocalyx has been preserved. It almost looks like dryer lint. That's all the components we've been talking about. So when you shed the glycocalyx, now you can end up with bare spots. We know what that does to your lawn. And then as you expose more and more, you set up this cascade of thrombosis. And we've seen this happen in an astronaut. Now, I'm jumping in a leap of faith that, and this has to be proven, so I'm saying potentially, we got to go back and start looking at why did this particular, and there was 2 astronauts, why did they have a jugular venous thrombosis? We know this jugular veins are distended. Now that doesn't necessarily mean there's venous hypertension, and I think that has to look at, I know that in the assessment of jugular venous blood flow stasis, it was done, really excellent paper. They did put a external bag that monitored with a sphygmometer how much pressure it took to occlude the jugular vein. The pressures were a little bit higher, but ultimately proving that is going to be important, because jugular venous distension, just like lower extremity venous distension, causes that. So ultimately you get high-grade thrombosis, and we see this in lower extremities. Now, glycocalyx is a significant part of the blood-brain barrier, and we know this to be true in multiple peer-reviewed papers now. And one of the questions I have is if white matter expansion is in fact responsible for the largest increase in combined brain and cerebral spinal fluid volumes post-flight, what's causing that intracellular compartment fluid shift? I think the glycocalyx component is one of those things now to start looking at. Also, the G lymphatic system has been brought up because we know now with these flow patterns, there's a significant change in how we can start to evaluate in light of the known G lymphatic component. So if we start to put this all together, and I think the multi-hit theory has so many intriguing components that help explain why this happens. In our patients, it's not one thing that causes lower extremity venous ulcers. It's always multiple components that we have to treat. And I think from a teleological standpoint, it's going to be the same thing, because the human adaptation to the environment is what makes the difference. And the environment, obviously, in low Earth orbit is significant, and it's going to be more significant as we start looking at the lunar surface and beyond. So as we start to look at insulin resistance, arterial stiffness, fluid shifts, the radiation component, of course, the increased CO2 within the spaceship component, all these things then add in ultimately to endothelial dysfunction. But again, pay attention to the fluid leakage, because that glycocalyx is right over that component on the fluid leakage. So when you combine what we now know for the 2021 paper with non-pathological versus pathological functioning and micro shear, and how that relates directly to endothelial nitric oxide synthetase, whether it's coupled or uncoupled, we can fit that model directly into this model, and now we can start to understand why that fluid leakage occurs. And this has been shown now in satellites where they've shown a decrease in endothelial nitric oxide synthetase in Cavalon 1, when by 3 days there's been a reduction of 26%. And so this paper, if you haven't had a chance to read this, I think it's worth integrating this into the components as well. And then Dr. Harris down at in the Harris lab at Louisiana has done some phenomenal job looking at microvascular perfusion of the retina, and it's in the glycocalyx component of it. So in this paper, he actually gets into the details of the glycocalyx component. And when you lose the glycocalyx, what you lose is perfusion of the different retinal layers, because there's the choroid layer that has its own perfusion, and when you get choroidal edema, you lose perfusion ability by rarefaction. So you can't perfuse components because of the development of edema. Then in the retinal circulation, which is again is different, there's multiple layers of that. So if you get reshunting or dysperfusion mismatching between these layers, you end up with ischemia. When you have ischemia, you end up with hyperpermeability, which results in retinal edema. And this was shown in 2010 by Dr. Vink and his lab over in Europe, that in diabetics, when you lose the retinal glycocalyx, you have in diabetics have a retinal glycocalyx that is certainly thinned, and they showed with sulodexide that you could thicken up again that glycocalyx to a functioning standpoint. And then just recently published was the vessel generation analysis, which looked at, and again, this is an N of 1. This is one astronaut, definitely shown to have SANS, and what it showed was the vessel perfusion was markedly decreased. So in this, and again, this is an N of 1, an astronaut after 6 months on ISS that had developed SANS, the small vessel the number of small vessels, dramatic decrease in both the left and the right. We know that the right tends to occur more so in sands, and that may be due to ethmoid sinus differences. There's obviously several different discussions about that. But I think the thing to focus on here is, again, microvascular changes resulting that are identifiable. And this was based on OCT data. There's not an OCTA that I'm aware of that's currently on the space station, but that's going to be obviously would be a valuable component. But using this software to start to look at OCT data is certainly incredibly beneficial. So I have a ton of questions. I would love to come down and spend time with you guys for a year because there's so many intriguing things I think to look at. So ultimately, though, what happens in that early launch window? Clearly, there's been a lot of research on that, but there's more work to look, because ultimately, does that launch result in some degree of relative subclinical microvascular ischemia reperfusion? Because we know ischemia reperfusion has significant impact on hyperpermeability. Then into the chronic in-flight, what happens from 24 hours to 6 months, what happens at deorbit. I would love to look at the glycocalyx component of an astronaut upon landing, because is the glycocalyx shed systemically such that with re-entering a 1G environment, it's just the lower extremities are so hyperpermeable, like somebody in the intensive care unit, the SVR is down, but it's partly because of plasma volume being reduced, but also just because of hyperpermeability. We know that then over a course of 7 weeks, that should rebuild so that those symptoms should get better. Of course, wearing compression stockings is very beneficial to that, but it'd be an interesting thing to look at. Overarching genetic, though, epigenetic adaptability and genetic adaptability, we can't change that quickly in these environments. Now, malaria is something good to, for some people helps prevent sickle cell disease. Where do single nucleotide polymorphisms, where are they beneficial? I have yet to see where they're necessarily beneficial. In our environment within our wound clinic, it simply makes it more difficult to heal wounds. And I think there's a significant analogies and pathways that we can see associated with SANS development. So my last slide, and then we'll do questions. So these are two of my favorite current textbooks. So Handbook of Venous and Lymphatic Disorders. I trained with Peter Glavitsky down at the Mayo Clinic, and he's now he's a phenomenal educator. The Handbook of Venous and Lymphatic Disorders does not have a chapter yet on the glycocalyx, and I think the Principles of Clinical Medicine Spaceflight, which is just an outstanding publication and incredibly valuable, it doesn't have the lymphatics and glycocalyx component yet, and I see that in the future both of these really pivotal books are going to end up having these new chapters in medicine to help us improve overall not only space health in low Earth orbit, but more importantly, what's going to happen in terms of demographic health in the United States. So thank you for your time. A lot of this is very quick, and I hope we have another opportunity in the near future to get together and discuss these in further detail.
Well, Dr. Melin, thanks for the presentation. We have a couple of people with their hands up for questions. Are you able to see those hands up, Dr. Melin? Would you like me to just call on them?
If you could, let me hop back into Teams here. I tell you what, why don't you go ahead and call it the first one while we're going from there.
Okay, Bob Sanders.
All right, thank you very much. So very fascinating. I probably cheated because I actually have a little bit more of a background than most. I am board certified in undersea hyperbaric medicine, have worked in wound care prior to coming to this. So really exciting. My question for you is, how quickly does the glycocalyx show these changes? And the reason why I ask is I actually have been doing research that we're about to publish, we're writing it up currently, that has shown, and this is going to be fascinating for you, improved cognitive performance in a hypoxic environment when using nitric oxide supplementation. So we were using a product called Neo40, patented by University of Texas researchers. And we have got improved PVT functions when we've got in randomized, basically a double-blinded controlled randomized trial at altitude. And I'm really curious if you think from your experience that a 15 or 20-minute hypoxic exposure would show changes in the glycocalyx, and can we start to look at that as possible uses in our case, and then pulling that forward, nitric oxide supplementation as a preventive measure or protective measure from SANS and some of the other spaceflight associated changes you're seeing?
Oh, I tell you what, I want to come down and spend about 3 months with you because I think you're spot on in your thought process. I don't from everything I've read, and again, peer-reviewed literature, you can shed your glycocalyx within minutes to hours. So the changes occur incredibly quickly, and as you saw in that 2006 slide, restoration takes about 7 days, but it can occur incredibly quick. So again, minutes to hours, you can see thinning to complete shedding. And again, think of patients that you've taken care of in the intensive care unit or in the emergency room bays that come in with significant trauma. You know, the ruptured AAAs I took care of, they look like the Michelin men literally within hours. So it doesn't take long to see shedding and those significant compartmental fluid changes. And I think the smaller the compartment, like the retina, it takes even less to see dramatic changes versus whole body changes. So I'm fascinated by your work, and I'm really looking forward to seeing outcomes and hearing more about this because I think it's a direct application of what we're talking about.
I would agree. Thank you very much, and I'll reach out to you as soon as this is over.
Please do. Thank you.
Great, thanks. The next one is Dr. Brunstetter.
Hi, good morning, sir. Thank you very much for a very interesting presentation. Really appreciate it. I've got a couple questions for you. Number one, are there any measurable biomarkers that can be used to, say, detect and track these vascular cascades, the inflammation, the lymphedema that might occur during spaceflight? And then question two, are there any potential countermeasures that might be effective in SANS? You'd mentioned several supplements. Some of those might be found in multivitamins like Centrum Silver. Is that a viable option?
Yeah, excellent question. So the biomarker question, there are many biomarkers that can be used. So the syndecans can be used, heparan sulfate, dermatan sulfate, chondroitin sulfate. One of the probably best ones to look at is going to be the albumin levels within urine, because we know that when the glycocalyx is shed, it impacts, and the glycocalyx within the brain, I think, is different than the glycocalyx within the kidneys. But when you start spilling albumin, it means your glycocalyx is shed, and there's a direct correlation between microalbuminuria and systemic glycocalyx shedding. So I think looking at urine, both spot urine checks as well as 24-hour urine, is going to be incredibly important to start to help to identify this. But I also think timing, you know, that window to look at, looking at after being in low Earth orbit for 4 weeks, I think is going to be different than looking at what happens in that first 24 hours. Back to Dr. Sanders' point, I think there's acute versus chronic, and there's adaptation. So I think looking at these, and I think looking at weightlessness is going to be a different thing than looking at it in some of the analogs that we have available to look at. But you've got to do the analog work, and then you can do the biosatellite work. You can, and to try to ascertain all this. But I think we've got to look at different analogs and then acute versus chronic adaptation. In terms of restoration, what we're finding in the wound clinic is typical multivitamin dosing is not enough to restore and replenish the deficit. So most of our patients, if they have an MTHFR abnormality, they need supradosing. So when we're doing dosing, we're doing like 1,000 micrograms of B12. We're doing 400 micrograms of folic acid. We're doing 100 milligrams of B6. We're doing a B complex. We're doing 10,000 of vitamin D. So 10,000 a day. In fact, Caroline Fife, who's in a wound clinic down in Houston, who's just one of the nation's foremost authorities, she's the one that really has helped me to understand D3, and now the data that's come out about D3 and exosome functionality and direct impact and endothelial cell function, D3 has to be at not just 2,000, not just 5,000. We have to go to 10,000. It's interesting because if you look at India, where obviously they're being ravaged right now by another wave of COVID, 2014 paper from a Journal of Nutrition, very respected journal. They estimated 70 to 90% of the Indian population was low on D3. And I'm on a manuscript right now that's coming out of the University of Minnesota Intensive Care Unit that looks at D3 levels in patients with COVID in the ICUs, and simply taking D3 had a 22% better outcome. So I think D3 is a huge component of this as well. So if I was gonna, there's data, we have to do this data-based. And so I don't have a good answer for SANS without conjecturing, but if I were to do it based on my 1G experience, we first of all, you have to identify who's at risk. And then I think we have to treat them from a super physiologic function, because there's already a deficit in how the gears work. But again, I think this takes data, and I think it's going to take time. But I think we got to get it on everybody's plate and de-silo this subject, because within our wound clinic, this remains a siloed subject. And we're going to be presenting this data at the American Venous and Lymphatic Society meeting in Denver in October, because hopefully if we can open the eyes and open the ears of people to understand this, we can impact, venous leg ulcers throughout the United States, not just in our clinic, because this is information we want to share that we know will benefit many people in the long run. So great question, really long answer. I apologize for the length, but I think it's such a loaded and important question.
Thank you. Thank you.
Well, we're at the top of the hour, 9 o'clock, and I know some folks have to go to other meetings at this point in time, but if Dr. Melin is available to hang around a few more minutes.
Hi, Dr.
Yeah.
Powers, I'm happy to sit here and answer as many questions as I can.
Well, great. Well, we'll say thanks to those who have joined us and have to leave, and we'll just hang on here a few more minutes for other questions.
And Dr. Melin, if you don't mind, I'm going to go ahead and display the disclosure slide that allows the participants to see the number to text in order to get CME.
Please.
Okay, next question is from Dr. Phelps.
Hello, sir. It's a pleasure to hear your lecture. It was fascinating and topic, outstanding lecture and overview of an incredibly salient topic.
Thank you.
Both terrestrial medicine as well as aerospace medical issues vis-a-vis clinical pathophysiology seen in prolonged spaceflight. I have an observation and maybe a question. Earlier in your discussion, I noticed you made repeated mention of the micro and macro shear function, or properties of the glycocalyx vis-a-vis mechanotransduction, when the glycocalyx is basically described as fine hairs. I think it was one of the earlier slides, but described as fine hairs, which as part of their function seems to be, it's probably multifold, but my question is what do you perceive their main, or maybe the main functions of these fine hairs? And I'm not sure exactly how to put this. I'm curious. I read through some of the articles, and I keep seeing the mention of mechanotransduction, but I'm kind of perplexed in that there's not much or no real discussion of mechanochemical transduction. In particular, I'm thinking of the work of Don Ingber at the Wyss Institute in Harvard. I don't know if you know Dr. Ingber. He's a cell biologist, bioengineer, and physician, and he's done a lot of work on mechanochemical transduction and the idea that things like these little fine hairs, microcilia, actin fibers, etc., actually are both a structure, a pre-stressed structure, but also a method by which mammalian cells transmit mechanical action and have a chemical, cause a chemical reaction within the cells. Most of his work has been done intracellular, but there's also an extracellular component. For example, the inner ear, the fine hairs in the inner ear, the apical stereocilia that transmit vibrations to the basal membrane ECM. And and through their physical distortion of the adherent sensory epithelium, and these are pre-stressed fibers, cause both a physical and a chemical reaction. And also the kidney, I guess the TRP family mechanochemical ion channels and polycystin A, or polycystin 1, polycystin 2 are also examples. So I guess my question is, have you thought about that and about the possibly the chemical component? I remember seeing your diagram, and you have epithelial cells with these little fibers hanging, basically creating a barrier. I suspect, I could be wrong, but suspect there's also a chemical function, a mechanochemical function that's contributing to both stasis, homeostasis, and in the case of injury, the transmission or the production of oxidative stresses and things like that. And I'll leave it there. But anyway, if you ever get a chance, Don Ingber's work is fascinating. I think that a lot of the authors that were in your referred in your papers and others kind of hit around that subject, but I don't see anything particular about mechanochemical transduction itself.
You know, I actually think you're spot on. And I think you just did such a nice job in a summary of exactly that continuum, because the mechanical transduction actually results in a mechanical chemical translation to cytokine production. So exactly. I think it's exactly the same thing. And I think it's semantics. And I think your description and summary was just beautiful. And, you know, again, I'd love to come hang out with you for a good month. I'll look up Dr. Ingber's work, but I actually think it's one and the same. And what you just described is exactly a component of the glycocalyx functionality. I like to think of the glycocalyx also like the Amazon forest. It's got in the various layers, you know, the Amazon forest has the, you know, the top tier, the mid, and the bottom, and the glycocalyx has much the same thing. So when it's in its fullness as a rheological barrier to impact, you know, with albumin, red blood cells, sphingosine 1 phosphate, maintaining the thickness of that barrier is critical in normal functionality. When you get down too low and start cutting too much down towards the stumps, well, now you've exposed factor V, and you've exposed von Willebrand factor and other things that lead to thrombosis, which again may be ontologically appropriate, but by that time you've lost your mechanical transduction component because it's hard to move stumps. But when you have the full thickness of the canopy, now you get that completeness of mechanical chemical translation in terms of production. So really valid point. You're spot on in how you just summarized that. Thank you for bringing that up.
I would just follow up if I might. I'd like to, if you have an email, I can email you a lot of Don's article. Phenomenal stuff. I've got pretty much every one of them, but the other, the basis of his work is the theory of tensegrity, which I fully believe that someday he'll get the Nobel Prize for. He's the guy's phenomenal scientist. But anyway, again, thank you very much.
Well, here's my invitation.
Okay.
I'd love to sit down with a cup of coffee with you, but please, yeah. Here, Rachel, will you share my personal email so that he can send me that? I would love to read that, because that's clearly something I need to incorporate into future talks.
Absolutely. Would you like me to put it in the chat, or for anyone who had any
put
questions?
it in the chat. I'm happy to connect with anybody that's on the line that has thoughts or wants to share information. Absolutely.
Of course.
Thank you, Rachel.
Thank you, Dr. Melin.
Thank you.
Great, thank you. And the next person with their hand up is Dr. Dan Woodard.
Hello. I have a more or less a clinical question. I have a patient with severe systemic sclerosis, and most severe symptoms are Raynaud syndrome with loss of several fingertips and chronic ulcerations, which didn't respond at all to calcium channel blockers or even to moving to Florida, which was recommended for. Have treated it fairly successfully with sildenafil twice a day. Yep. So, you know, nitric oxide is clearly a key factor here, but it obviously affects the glycocalyx as well. And I'm just wondering if any of your other areas that you mentioned in terms of micronutrients or other factors might be helpful.
Great point. So all our patients with CREST syndrome, our patients with systemic sclerosis, our patients with lupus, all the upper extremity, we're putting them on systemic. Again, I look at all those people as uncoupled. So I'm putting them on that, what I call our new form of TANG. So the B12, the folic acid, the B6, on the high dose vitamin D. And then I'm putting them also on the micronized purified flavonoid fraction. So specifically hesperidin diosmin. There's great data. There's one unpublished paper that I've seen manuscript, but there's also published data from Europe about utilization in this area. And I would put them on an MPFF lifelong. I'd probably put them on all this stuff lifelong. And I think the other thing we're using topically is a poloxamer. So poloxamer 188, which is known to help stabilize bilipid membranes. The brand name is Plurigel by Medline. We use that. That's our go-to on all those types of ulcerations. So topically, 2 to 3 times a day, and then we're again those wounds. I think you have to treat from outside in as well as inside out. Because we know that if they've got that occurring in their fingertips, it's certainly occurring in many other organ systems where we can see downhill negative impact. So we've had really good success in treating the CREST patients with this, as well as patients with calciphylaxis. We put them on the exact same regime in terms of management, because again, I think at the end of the day, endothelial cell management is the key to getting systemic wellness as well as treating the local wound environment.
Thank you.
Thank you.
Great. And the next person up is Dr. Ann Sung.
Hi, Dr. Melin, can you hear me?
I can, thank you.
Perfect. Thank you so much for your lecture. It's like you said, I think this is a paradigm shift for me as well, because I'm in the ICU, I'm in the ER, so I can this really explains a lot of the diseases that we see. And I do have 2 questions for you. One is regarding the dosing and route, and then the second one's regarding the data collection. So I wanted to tag on to Dr. Bronsetter's question regarding the doses. I got the doses that you have mentioned, except for the vitamin C and hesperidin. And have you found any differences in terms of IV versus oral vitamin B? Because they have all these B vitamins, IV bags that you can get commercially now. So I'm just curious your thoughts on that. And then number 2 is, if you could collect one type of data from the astronauts to study this, what would it be?
So in terms of route administration, clearly in the ICU, a lot of, I think, microbiome, so GI microbiome is impacted. So clearly, if we can get an IV in that time, there may be some significant benefit. And you've seen the data on D utilization as well. And even the high dose vitamin C use in the intensive care unit has had some significant benefits. I think you have to do it totality. I don't think any one thing is the key. And I think we have to, the more we address, because it's a multi-hit phenomenon, I think we have to hit it on all angles to have an impact. Does that answer part 1 at all?
Yes, and what about your thoughts
Okay.
of, your patients doing the IV bags of B vitamins versus the oral?
Yep. And I think it just has to make sure, I think we tend to underdose, in all honesty. I think patients, by the time they've gotten that sick, they're at such a huge deficit. And I have people come on up to me and say, you're giving 10,000 of D3 a day? And it's like, yes, we are. And here's our outcomes. And it's really been beneficial. So especially in the B vitamins, which are water soluble, the worst we're going to do is create expensive urine. But I think super saturating to get the gears to function, especially in our patients with that have polymorphisms, we have to help their gears to function correctly. And the data shows that kind of dosing clearly helps. If I could measure one thing on a astronaut in low Earth orbit to look at glycocalyx functionality, what I would probably honestly do is look at a indirect measure. I would there's something called a glycocheck. It's a really small, lightweight probe that you attach to a laptop and the software. By putting it underneath the tongue, you can measure the sublingual microvasculature down to the 10 micron, 5 micron. It'll take 30, 40, 50,000 different vessel cuts. And what it's looking at is perfusion boundary regions. So think of a bowling alley with the safety gutters up. And so the bowling ball is the red blood cell, goes right down the middle, doesn't deviate at all. So that's normal. So your perfusion boundary region number would be low in that case because the glycocalyx is intact. So the red blood cell just goes straight down. They know that when the perfusion boundary region number increases, now the bowling ball is going from side to side to side. That means loss of the glycocalyx, so you have more deviation in how the red blood cell travels. I think the ability to use that probe, because that's something that literally 12 minutes after launch, you could stick that underneath somebody's tongue and ascertain what's the glycocalyx like now. Do it an hour later. You could do that every single hour. It's non-invasive. It's incredibly lightweight. It would give us an indirect measure that ultimately you could complement with biomarkers. I don't think astronaut time is so critical every single minute. So I don't want to say that that this shouldn't be able to be done, but I think this would help a lot, because if we see perfusion boundary regions change in that first, say, 23 hours, we know that there potentially is a high likelihood of glycocalyx shedding in that initial post-launch window, and then it sets up a adaptation state for the next, whether you're up there for 8 days or 6 months. And now you can look at how does the body deal with that adaptation. And the glycocheck has actually been used in many intensive care units now in Europe. It's a standard of care in multiple places to look at glycocalyx restoration and how people are recovering. And it's really been, there's at least 2 papers now that have been studied directly on monitoring COVID. So shedding the glycocalyx related to COVID, restoration with treatment. So I think there's enough data out there now on the glycocheck that would be my go-to indirect first on my wish list to utilize.
That's fantastic. I had not heard of it, so I'm going to have to research and look it up a little bit more.
And I can make your life so easy and send you 2 or 3 studies directly about the glycocheck if you're interested. Just email me and I'll send you 2 or 3 papers and save you the extra work.
Oh, yeah, that would be fantastic. Thank you. And the last thing is the dose of the vitamin C and the hesperidin.
So on the vitamin C, we're using mega doses. I use actually a very specific form of, it's called ester C. And the reason I use ester C is you can get it on Amazon. It's 1,000 of vitamin C, plus it's got a hesperidin diosmin component to it. And on the hesperidin diosmin, and again, I have gotten an honorarium for Primus, who makes Vasculera, which is a micronized purified flavonoid fraction. Here's the problem with Vasculera. It's expensive. It's $120. Every 3 months for 650 milligrams, but it is FDA certified. It requires a prescription. I would call that one the Cadillac. But if you're going to do correct dosing, you have to take 2 tablets, which is now $240, and nobody's paying for it. It's GRAS, generally regarded as safe. It's considered a food as medicine, and it's so I think that's the best. Then we use on Amazon, we'll get one called Nuspera, and then there's another brand by BioSupport MD. John Schubeck, who's a vascular surgeon, great guy. He helped develop that company, and I have no financial ties with them at all, but they make a lymphatic form and a vein form. I think that his formulation hits the sweet spot because it's the right price, and he has I think it's a guaranteed product that we know in terms of deliverability, as long as your microbiome's working, that you're going to get the right dose. Because it's hard to eat 20 oranges and 20 orange peels a day, you know it. But I think the hesperidin diosmin, we're going to see more and more data coming out in the United States. There's 10 RCTs that have been performed on Europe on this specific flavonoid. And I think that this will have a significant component. I predict in 5 to 7 years, this will be a mainstay of a treatment for diabetics. When you get diagnosed with diabetes, you'll be put on this flavonoid along with your insulin, along with your ACE inhibitor, as well as with your statin. I think it's going to be proved to be that important.
Would you say, one last question to follow up? I know I'm taking up quite a bit of time, but one last thing. What is the one supplementation, micronutrient supplementation, that you think is the most effective out of all of these then?
I don't think you can. I don't think you can pull them apart, because if you if you just take the MTHFR cycle and you look at going from 5 MTH to from 510 to 5 to, if you look at that circle doesn't work without folate, B6, B12. You have to hit all cycles if you're going to maximize homocysteine reduction. And even, homocysteine is not even so much the issue, because it's been proven that homocysteine alone is not the problem. So I think it's a relative component, and it's organ specific. I think if you look at those, plus then there's a form of BH4 that you can take called, I think it's cyopterin. Citrulline, now there's a whole chapter just on citrulline alone, which, right, L-arginine to citrulline plus nitric oxide. Citrulline has a huge independent impact. BH4 has independent impacts. So I don't think you can take the circle apart and end up with the same totality of outcomes that we would expect. I think you have to, again, like gears in a clock. And I think, to me, this is like this is like an Omega wristwatch, right? Every gear is, excuse me, every gear is important. And I think we have to make sure every gear, the teeth are fitting, and I think we have to make sure it's oiled. And I think we really have to treat this mechanistically as a fragile system that requires a lot of support, especially in the extremes of environments like intensive care units. I think diabetes is an extreme environment for a typical body. Clearly, low Earth orbit is an extreme environment, just like Antarctica, just like being down in the Nemo facility. So again, great demographic applications in the long run of really simple things that I think we can repurpose as we look through things like the glycocalyx with a new lens.
Thank you for all the analogies, explanations. Sounds like we need to explain all of this to our patients in terms they understand, so that they will be compliant with all these micronutrients. So,
and please email me so I can send you those articles on the glycocheck. I think you'll find them fascinating.
Sounds good. Thank you.
Thank you. Thank you.
Thanks. Next question is from Emily Stratton. Dr. Stratton.
Hello, tuning in here from the Mayo Clinic. Thank you for your presentation.
Are you Mayo Clinic Rochester?
Yes.
I was born and raised in Rochester and went to John Marshall.
Oh, very nice.
And I did my general surgery residency there and my vascular surgery fellowship. So it is the Disney World of medicine down there. You guys do a fabulous job.
Yes, oh, thank you. Yes, it really is. So similar to what was just asked by Dr. Sung. So as you mentioned, low albumin levels causing increased vascular permeability. Certainly we see this in the ICU setting and sepsis presentations. Have there been many studies on oral albumin or a high protein intake versus IV administration of albumin affecting glycocalyx functionality?
All the studies that I've read to date, especially when it comes to looking at VTE, right? So venous thromboembolism and albumin levels, it's been mostly ICU patients. So it's been primarily from an IV administrative standpoint. So I haven't seen the data on oral protein supplementation. Clearly, most of our patients in the ICU, hopefully they're getting tube feeds. But again, I think microbiome, gut hyper permeability, because of the component of why they're in the ICU, probably has an impact on absorption and in terms of how much is actually getting in to help in terms of restoration. So I think that most of the data I've seen is IV. But again, I think that's a distinct and different patient population. And so I have not seen the data on oral protein supplements and in terms of restoration of the glycocalyx, but most of those people are going to have a glycocalyx that probably is okay. But I think you're really raising a good point that say that if we took diabetics with microalbuminuria, which we know have some degree of thinning of the glycocalyx, and then at what point does thinning of the glycocalyx result in a clinical change? So what's the tipping point? When do you start to lose renal function? When do you start to develop diabetic retinopathy that changes into the flame hemorrhages, macular edema, etc.? And then when you start to lose, the tissue loss and end up with the toe and the leg amputations. So I think you actually raise an incredibly interesting point. It requires sensitivity. It requires the right biomarkers. And I think that the albumin, of course, has to be considered a component in light of the other things that are necessary to make the gears of the clock run. So I always hesitate to focus on just one thing, taking it out of context, because I don't think protein alone will ever result in full restoration of health in some of these critically ill patients or these patients that have chronic inflammaging states.
Right.
And I don't know if you've met Tracy Weisgerber down at Mayo, but she works in the hypertension department. She actually published a really phenomenal study on preeclampsia, glycocalyx shedding, and they used the glycocheck. So there's a glycocheck in Rochester that Tracy has, and she spent 6 months in Rochester, 6 months in Germany, but she might be somebody to connect with as well. She's done some phenomenal research in this area.
Oh, that's wonderful. I'll have to get in touch with her. Yeah,
and feel free to email me. I'll email you her recently. It was published within the past year. Really scientifically well done study. But I think her evaluation of preeclampsia patients and glycocalyx shedding, that sets the model to start to look at other opportunities and other pathologies.
Right, that's great. Thank you so much.
Great, thank you. We have time for one more question before we have to wrap up. So Dr. Doug Ebert.
Hi, thanks for the presentation. Is really stimulating, obviously, based on the number of questions and discussion we've got going here. So my question is, how much of this has been studied, the glycocalyx has been studied in larger vessels on the arterial side and also specifically on the venous side? I mean, obviously, particularly in the venous side, you're not going to be dealing with the nitrous oxide. It's more of just a mechanical flexibility associated with the venous vessels. But as you touched on the thrombosis that we've had in space flight and also the distension. I mean, we see there may not be a large pressure gradient, but whatever pressure gradient differences that we have in flight versus on the ground, it's creating a huge difference in distension in our large vessels, particularly in the upper part of the body. So it seems like we may have on the venous side of the glycocalyx and some of this permeability is also at work there. We're looking at a maybe not a pathological pressure state, but certainly an abnormal distension and potentially a much larger pressure gradient than the venous side is used to seeing. So I'm just curious how much work has been done on the venous side with glycocalyx and those interactions.
Doug, I'm so glad you brought up this question, because this was one of the significant paradigm shifts for me in terms of thinking from macro to micro. I had to start working backwards. So, and I'm going to use the aorta as an example. When I was doing open aortic surgery, and we'd be in there in either a abdominal aortic aneurysm or occlusive disease where we were doing like an aorta by fem bypass, when you look at the adventitia of the aorta, it had a significant collateral development, unusual and different than in the normal anatomy of an aorta. And of course, the aortic adventitia and media is dependent upon microvascular perfusion from the vasa vasorum. So the intima on an aorta, the media and adventitia is not getting blood flow from the lumen of the aorta, it's getting it from the outside in. And once we start to think about that, it changes the paradigm in terms of, again, shifting back to microvascular components. So if you apply it then to venous, again, thinking about femoral veins, popliteal veins, the tibial veins, I actually think that we have to start thinking outside in those vessels. So start thinking about the microvasculature that, and obviously the perfusion of the adventitia of the veins and pressure relationships are dramatically different than the aorta. But I think the baseline microvascular based on Fink's principle, because you have to be within 0.1 microns for oxygen and nutrient delivery. So the large veins are still dependent on the vasovasorum of the microvasculature perfusion and health. I think that those vessels are the first ones impacted long before a clinical, before we notice it clinically, that sets up the long-term pathology that we see then in 10, 20 years down the road in venous disease. Now that's going to be hastened by development of a large vessel thrombus. But chronically over time, as you shed the glycocalyx and the microvasculature feeding the larger veins, that's what's ultimately leading to the problem. So I certainly can share with you the Annals of Vascular Surgery article. It's out of Portugal. They've written 2 good articles on this. There's more and more data coming out on this, but those 2 papers are kind of the sentinel papers that really that caught my attention. Part of the problem on the venous side is in economics. If it doesn't make money, that does impair to some degree the research component. And I think, and this is one of the reasons I'm co-chair for the wound section out at AVLS, this American Venous and Lymphatic Society in October. And this is really one of the things we're going to highlight. We have 3 international experts in the glycocalyx coming out to talk at this meeting. So we have Laura Santambragio, we have Ino Ebong out of Northeastern, and we have Bing Mai Fu, who's out of City College of New York. And they've written some of the Sentinel papers. So they're coming out to this meeting first time ever to talk specifically about this and to talk about this in large venous. So I'm hopeful, to your point, that this stimulates more work to be done, because I think that the sooner we start to treat this upstream. So if we have patients that are a C2, C3, so type ordinary varicose veins or varicose veins with some beginning edema, which we know is lymphatic dysfunction, I think we can prevent patients from going to the C4, C5, C6 status, where they have the lipoddermatosclerosis, the dermatocitrin or hemocitrin deposition, all the dramatic dermal changes that occur that set patients up for development of ulcerations. But all those dermal changes are chronic ischemia changes. That's why these changes are occurring. Lipoddermatosclerosis is chronic subcritical microvascular ischemia, and that's eventually what results in the ulceration. So I think you raise an excellent point. So much more work needs to be done in this area. It's education and awareness to get to that point, so that ideally we can get the grant funding and then get people enthusiastic. And I look at today as a great example of just, as we start to understand this and collaborate and break down silos, there's a lot of things that a powerful group like this can do moving forward, both for astronauts, astrocivilians, as well as just for demographic health and all the patients that we're serving right now from a terrestrial standpoint. So excellent point. I appreciate you bringing that up, Doug.
Well, thanks very much. I'm going to need to bring this to a close. And Dr. Melin, really appreciate your presentation. It's fascinating. As you can see, everyone really enjoyed it. We particularly appreciate Dr. Cesaro's work for recommending that you speak today. I think it was an awesome selection for us, and definitely informative. So I also want to thank all the participants who took part in the session today. The next speaker will be on June the 8th, and the speaker will be Dr. Alexandra Sinclair from the University of Birmingham, England. She's the lead clinician for treating idiopathic intracranial hypertension, and she has the largest clinic in Europe for treating these patients. She has expertise in implanted intracranial pressure monitoring, and she's published a paper using optical coherence tomography for the indirect measurement of ICP. So that should be very fascinating as well for us. And of course, Dr. Melin, you're welcome to join any of our grand rounds and listen into all of those speakers as well. I want to give a particular thanks to Rachel Fowler for organizing the meeting today and to make sure that everything was working correctly. She is the one who is helping us in processing the continuing medical education and maintenance of certification. So I'm going to go ahead and turn it over to Rachel for any additional comments.
Thank you, Dr. Powers. No additional comments other than if you missed the event ID, you can email me, and it's also in the chat twice.
Great. Well, thanks to everyone once again, and particularly thank you to Dr. Melin. And we'll go ahead and close the session today. We'll see you next month.